So, before we start, I'd like to lay some groundwork for us to think through a couple of things as we progress, so that also we can engage ourselves mentally. So 24% of the world's health burden is within Africa. That is roughly a quarter of that. And then we have 3% of the health workers of the world within Africa. So I want you to think about that disparity. We have a quarter of the world's problem in terms of healthcare, and we have 3% of the resources, that is the health workers, the labor. And then within sub-Saharan Africa, we have 1.3 healthcare workers for 1,000 people. The recommended threshold by WHO is 4.5. Basically, what I'm trying to say is that we have a huge gap. And in the field where I come from, which is radiology, we have an immeasurable disparity. We have at least 14 African countries without radiologists. In Kenya alone, we have 288 for what I think now should be 56 million Kenyans. We have around 50 in Tanzania. Tanzania has more people than Kenya, 65 million. We have some countries, including Ethiopia, that don't have any. We have other countries that even have 4 radiologists, like Botswana, they have 4, and none of them is within Botswana. We have countries that don't even have courses that teach radiology. And that is just a small space. We have other areas like surgical workers. Only 5% of Africans have access to good surgical healthcare. So I want you to think about all of those different items as we progress. And I want you to think about these two in the sense that Sub-Sahara has a huge burden of infectious diseases. We have malaria, we have TB, we have HIV/AIDS, we have a couple of other diseases that are very particular to our region, which we call the local disease burdens. And then at the same time, we have devastating consequences from conflict. I think you have seen what is happening within the Congo. You see areas like Ethiopia usually having strife. We have Sudan. We have a couple of African countries that have a lot of problems. And then at the same time, we have withdrawal of aid. I think you've seen the discussions that are going on within our country, within South Africa, and other parts of Africa. I want you to think in depth about these so that when we get to the point where we're talking about how we can impact healthcare using technology, then you can also have thought through how we can come up with different solutions. And as we do these, I want us to think about these 4 items. How do we build healthcare systems where there are none? How do we rebuild where they have been destroyed, like in countries like the Congo? How do we strengthen what we have, like in our country, Kenya? And how can we leverage technology to accomplish the 3 different areas? So the first thing we're going to do is to have a couple of standards so that you can see a representation of what we have locally. Can we give a round of applause for that?
All right, thank you so much. I work for Innovate Solutions Limited, which is a startup that is focusing on providing emergency medical services to Kenyans and hopefully to Africa in the next 3 to 5 years. As I was preparing for this speech in the morning, nilikuwa nakuja kuwapea stories za Java. But I realized how important the solution that Alex has built is also to me at a personal level, because this Wednesday I'm taking my mom for an eye surgery. She's almost becoming blind, and that's because about 20 years ago my dad hit her with a metal on her head, and for a very long time she didn't know that there was no blood supply to the eye. And I just realized that if my solution was available then, as it is available now, to survivors of gender-based violence, then maybe we would have saved that eye. So yeah, next please. So I started Ambulex out of a situation, a GBV situation, gender-based violence situation. This woman, she had been stabbed by the husband about 7 times, and I tried getting her an ambulance, and I could not get an ambulance in time. Unfortunately, she died, and that got me thinking. You watch a lot of American movies, and you see people calling for ambulances, and within 5 to 10 minutes, an ambulance is there. So I asked myself questions: why is it not happening in Kenya? And that's how I thought about what are the realities in Kenya. We don't have very good roads, we don't have very good ambulances, and that's why now Ambulex exists. Next, please. And so more than 70% of Kenyans, and I'm sure even in this room, more than 90% do not know how to call for an ambulance. If one person drops down right now, what would you do? Scream, right? Yeah, so you can imagine we would say we are people who actually know how to, be educated, we know where to get information from. So how about that Mama Mboga in Kibra or in Korogosho? This is not someone who has access to information very readily. And so this is why we exist. We want to provide emergency medical services to the more than 70% of Kenyans that do not have this access. And this is because, one, the cost of accessing ambulances is quite high. It can go between 5,000 to 120,000 per trip, depending on what is needed in the ambulance and how far the ambulance is taking you. Beyond that, we're talking about access. Ambulances, like say for example, you go to some place in Mooni, I don't know whether you know Mooni, an ambulance will not be able to access such a hilly place. And so basically what we do, next please, we have different ways in which you can access ambulances through ambulance. One, you can give us a call, that's the easiest. But then we also do have an app where you just tap and the closest emergency medical technician to you gets to you. They stabilize you, and if there's need for you to be taken to an ambulance, to a health facility, then we send an ambulance. Beyond that, we also have a USSD platform where you just dial some specific numbers, and that takes you directly to how you can access an ambulance. So that's how we do it. We do not own ambulances. Ours is an Uber-like model. So what we've done is provided a platform for those who own ambulances, individuals, schools, or hospitals, and even churches. You find that there are those that own ambulances. What we provide is that link for them to customers. Next, please. So this is our tech. You can call. We have a dedicated line. It's not toll-free as yet, but we're working on that. That's the app in the middle. And lastly, at the far left, that's our USSD platform. And then, because we have more than 300 EMTs within our platform and ambulance providers, next please. This is how it looks like. The first picture on the right, that's the response app for emergency medical technicians. And that's the board that shows you how they are scattered across the country. Yes, please. So to cover costs, or to address the issue of costs, we have a subscription model where we are working with individuals and families. They pay certainly less than $30 a year, and that covers you and your spouse and kids. Then we have for corporates. We also do work with the government. Specifically, we are in conversation with the Affordable Housing Project, so that we provide them with emergency medical services for workers on site. I can't see them very well. That is next, please. Yeah, so far we registered in 2019, but we began officially operations in October of 2021. And so far we've brought in close to $160,000 in revenue. We have more than 20,000 subscribers in our platform, and we have responded to next list. We have responded to more than 15,000 calls since we began, and I'm very passionate about responding to gender-based violence. And more than 60% of those who are calling us for GBV are actually men. And how we respond, we do this is we work with the police to respond. We get to you, evacuate you to a health facility, and if there's need, we can then take you to a safe house. If you want to place charges on the perpetrator, that's on you, but we are very keen on ensuring your safety and health. So those are our numbers so far. In terms of impact, next please. Looking at how big this market is, we're looking at $272 million in terms of our market. And we believe that this is something we can actually achieve. We've looked at our projections for the next, for the next 2 to 3 years, and we see that we should be able to. Next, please. There was somewhere. There's something that you've. Yes. That's one. There's one on finances. I can see it. No, don't do that. Yeah, but we see that we should be able to break even in 2027. We are raising $1 million in equity this year, and 500. There's some. I think there's some slides that are missing. In equity this year, and some 500,000 in grants. Next, please. And how we intend to do this in terms of just growth in the next 3 to 5 years. We are going to into a partnership, and we've already done that with 2 insurance providers to provide medical insurance and bundle up emergency medical solution for their medical covers. We aim to train 3,000 emergency medical technicians. Actually, the idea is to provide employment opportunities to more than 10,000 EMTs and paramedics. We are also building an end-to-end referral system so that when we pick you in your emergency situation, let's say for example you're in a road accident, the hospital that we're taking you to already knows that we're taking you there. They have your health information. They already know if you have insurance or not. And one of the things that we do is when we are onboarding our customers, we also ask you to take SHA. Whether SHA works, we also ask you to take SHA. I'm not advocating for the government. I'm saying this because it has paid for my mom's surgery the first time, and it's paying for it now. It paid for a friend's surgery 2 weeks ago, so I know in that way that it works. Yeah, so we urge our subscribers to also take on SHA, so that when an ambulance comes for you, you're not worried about paying for the ambulance. And then when you get to the facility, because SHA takes care of inpatient, you're also not worried about paying for that, right? Yeah, so that's our growth strategy in the next 3 to 5 years. Thank you so much.
Our controller, kindly put up Neurolabs Africa.
As that comes up, I could probably start with an introduction. My name is Tom Kinyanju. I'm a co-founder at Neurolabs Africa. I'm background in machine learning in data science. So at this today we'll be looking at, for this case scenario, we'll be looking at AI in radiology. I know Mukiri has mentioned a little bit of the statistics, but I'll go through a bit more. So what we do is we impact healthcare using technology, more specifically deep learning and computer vision. Initially, we thought why patients do not, or rather wait for so long to get analyzed lab results is because there are very few specialists. Like when you go to the next slide, we could see the numbers. Like for instance, 2/3 of the world have no access to radiology. We have countries like Malawi have a 1.5 billion ratio. We have others with even outsourcing radiology, for instance, Botswana. So we thought that this was it's actually a big problem. But what we didn't realize is that every medical image needed to be signed off by a radiologist. So you do not kind of sideline them because in case of a medical misdiagnosis, then they come in to help you. They come in to, they have taken responsibility. So recently, we did a pivot, which I will be explaining more about. So averagely, patients will have to wait for 2 weeks. That's why you told in your local hospital, we only do imaging once a week. And that's because the radiologist comes in that hospital only once a week. As of last year, we had around 288 radiologists in Kenya, according to the Kenya Radiologist Association. But when you have diseases like pneumonia, killing in less than 3 hours, especially for children, then longer wait times are definitely a death sentence. Actually, about 15% of all deaths in Africa would be avoidable with timely diagnosis. We have timely interventions. If you get an ambulance on time, then you're most likely to save a life. So what we have developed is a picture engraving communication system, an AI-powered picture engraving communication system. So first, what it does, it's not mandatory that the radiologist has to be at the hospital to analyze your medical image. So we connect to the hospital or with a console in the hardware that is in the radiology lab. So we enable radiology. That means radiologist doesn't have to be physically at the hospital to be able to have a look at your medical images. Then from there, we pre-screen medical images for common indicators of pneumonia, tuberculosis, and lung cancer. We also automate reporting using an LLM. So instead of spending 5-10 minutes doing the report, so we're able to automatically generate the report for them. And then from there, they can be able to correct it just signing off. So improving time that they spend on medical image by less 50%. So we have diverse users, hospitals, diagnostic labs, and radiologists themselves. Today we are finding our USP of being radiologists, because radiologists feel better using our platform because it makes them have better turnaround times. Normally, mostly, they are paid based on how many images they do in a day. So the more the images they do, the better pay for them. So our software helps them achieve that. We are tapping into a 2.8 billion market, targeting around 3% of our market. What informed our clinical, or rather our pivot, was a clinical validation, which we worked with UNICEF Innovation Fund. Then after that, we worked with Fieldglass to be able to build the picture archiving communication system. So what we would say our USP is, first of all, we use local data to solve local disease burdens. So like Judith had mentioned, probably when pneumonia might not be prevalent in the West, so we don't find a lot of data sets on that or tuberculosis. But now since it's prevalent here, so we need to collect more images to be able to identify some of these diseases. I'll showcase some of those. So very quickly we'll go to the demo. So this is our platform. Once you log in, this is what you see. So what happens at the console is we upload an encryption to ensure that hospital data is first of all, it's private information, and secondly, in case of a data breach, the hospital, a hacker or in case of a data breach, you actually don't get the actual images on cloud. So what you get is an encryption. Think about this as how you would scan a QR code to access a document, maybe a PDF. So on clicking basic viewer, the encryption is reconverted back to its original form, and that's, for instance, a CT of the abdomen. So first of all, what we do is automated anatomy segmentation. So on clicking segmentation, you automatically segment the entire anatomy for this immediately. So traditionally, a radiologist will have to use annotating tools to be able to annotate the different anatomies. For instance, if it's the cellular white matter and the cerebral white matter. So you're able to do this on a click. So on clicking segmentation, you'll be able to automatically get the anatomies for the entire, this is an MRI of the head. So yeah, so different colors for the different anatomies. Probably then we could go to the teleradiology features and the NPR. So you're also able to automatically generate a sagittal coronal view. So this generally has to be generated by a radiographer. We're able to do that on a click of a second. So we just onboarded our first user today, actually. So yeah, so that's all when it comes to knowledge.
Let's Africa.
Good afternoon once more. I'm Dr. Austin Omune, co-founder and CEO of Negasment Limited. Thank you for the opportunity. Yeah, so I think I'll begin. So for us, we stumbled upon the problem with our experience in the healthcare sector when we see patients who would be stuck in the ward, not able to access the appropriate therapy, and most of the time the issue was due to lack of appropriate equipment. And we saw this as a huge problem, which resulted in patients staying for long periods of time in the hospital, gathering costs, and eventually sometimes even losing their lives. So just to highlight this problem, we found understood that this problem is brought about due to a broken supply chain, where medical equipment is too expensive. There's a huge upfront financial strain and technically lack of the appropriate equipment, and also not a way of being able to effectively manage this equipment. And in terms of statistics, we found that 70% of the medical equipment in the African sector was outdated. Next. So we sought a solution which we call Clinic Builds, which is a platform for healthcare institutions to be able to share critical medical equipment, for the manufacturers to be able to lease and track this medical equipment, and this enables them to receive the payment only when the device is used. So basically, democratizing the access of these critical, expensive medical equipment. So with this, hospitals which are marginalized are able to access world-class medical devices. They're able to share within clusters where we enable them to book, effectively plan their procedures, and only pay by use, increasing their affordability. And the manufacturers are able to track using IoT, and then they receive the payment only when it's used. So they're able to access more markets and leverage this technology. So how does it work? We cluster the hospitals in the same geographical region, and using data analytics, we're able to predict the equipment needs, and then enable how they'll be able to book for these procedures and only pay by use. And also with the IoT, the manufacturers are able to see every time the equipment is used and then receive the payments only when it's used. So basically relieving the need to pay huge costs upfront for medical devices, and so basically it divides the cost between different hospitals and clinics. So as you can see, the manufacturer is able to track, and also we're developing a wallet which will enable investors to be able to assist the hospitals to purchase more equipment, which they're able to make sure they're effectively used and they can lease to the neighboring clinics and hospitals. So the model is two-tiered, with the booking fees, the therapy per service, where payment is made every time the equipment is used on an average of about 2.5% of the cost of the equipment. There's a subscription fee for the manufacturers to use the platform and to be able to lease the equipment, and the hospitals are also able to track effectively the equipment and notice the use. And for the asset financing wallet, where there's a 10% commission for every equipment that is financed to the hospitals. And we provide a free inventory management and procurement software. So this is ideal for cluster hospitals with their several branches, public healthcare referral hospitals, clinic chains, and manufacturers as well, and also healthcare investors. Yes, we've been able to serve over 119 hospitals from large public hospitals such as Kenyatta and the Defense Forces of Kenya, to specialized clinics in the peripheries of Nairobi, in Thika, and several other areas, indirectly treating over 150,000 patients and over 400 bookings and a revenue of over 730K. So we foresee this as a huge market, basically being able to target all these hospitals in the East African region, and a growing market as well, basically being able to employ payment per service for medical equipment. So some of the things that make the platform stick out is the IoT tracking of the equipment, the therapy pass service, and the health demand clustering and aggregation, where we're able to predict the specific medical equipment needs for the hospitals. So we are experiencing steady growth year on year as we are able to onboard more hospitals, with last year being able to cross the 250K annual revenue, which we expect to double this year. So these are some of the partners we've worked with in terms of being able to improve the software, asset financiers and investors who are able to help finance some of the purchase of the equipment and some of the medical device manufacturers. So we are hoping to onboard more hospitals this year, be able to expand into the neighboring countries, build the investor wallet, have more people be able to invest into this wallet, and also increase the manufacturers that lease the equipment out to the hospitals. So thank you. We'd like you to join us to create a circular economy that revolutionizes how we're able to access medical equipment and provide the best of care in the African continent. Thank you.
Wow, thank you so much. You have the next time come on stage, Daniel. I think this is Marcy coming up, right? Yes, you're very welcome.
Good afternoon, everyone. My name is Marcy Mwende. I'm a co-founder of Thalia Psychotherapy. Thalia is in the business of doing focusing on mental health with a very key interest on prevention, because that is where we believe if we start as Africa, we can get it best. Is it there yet? Yeah, so we're just here because we want to basically enhance mental health accessibility across the African countries. Okay, yeah, just like I was saying, we want to enhance mental health access and the outcomes through the technology that we're currently having. And at Thalia, like I said, we focus more on the prevention element. So in Africa, we have, next please. Yeah, those are facts. In Africa, we have over 90% of our patients with mental health issues that go undiagnosed. Everyone that walks to a hospital, 5 will walk in there because they're saying, I'm having a headache, backache, and all those things. The doctor will not focus on anything else apart from what you have said. That's why we are saying that we have those numbers that go undiagnosed in our country. And we believe over 13 million Kenyans have mental health issues. So just imagine if all those Kenyans were aware about their mental health, what would happen? I think our country would already go into a crisis. I think so. So the opportunities that we have is because we already have technologies that are already there. We have our mobile phone that is already in use across our African countries. So we are using that to ensure that the accessibility is there. So that we are, as at Thalia Psychotherapy, what we are doing, we are already using the channels already in place, like the phones, the what is it called? We have the phones already, we have the USSDs, we have, next please. Yeah, so that is how our solution works. we already have, we're integrating these services already into our healthcare system. If you walk into any facility, the facilities that we've already been able to work with, they already have a code. Like if you go to that particular facility, while you're waiting to be served, then you dial that number and you take a test using the already approved documents from the World Health Organization, which will ask you like 2 questions, which we call it the PHQ2 or the PHQ9, Patient Health Questionnaire. So as you're waiting to see the doctor, then you can start dialing and he will ask you questions. Depending on the answers that you give, by the time you're seeing the doctor, then the doctor is able to look at you holistically. Just like we get our vital checks. They check your weight, they check your, your pressure and all those things. You've already checked also by dialing that number, you've answered questions that guide you to checking on how your mental state is and is feeling like. So the doctor is able to look at you in a holistic manner. So that is how it works, like I was explaining. You use your phone, you're able to dial the number, then you answer a few questions. It can range from 2 questions to 9 questions. Then, depending on how you answer, then there's also going to be another check that is going to be done virtually, because before now you are able to, we can say that you really have a mental health condition that needs to be assessed. So we believe everyone that is in, across the countries that we currently operate in, everyone at least has a phone. That's why we believe it's the most effective and efficient way of being able to get everyone to know about their mental health status using the phones that they currently have. So like I was saying, we have all those channels there that we currently use. If you're on Facebook, if you're on Skype, basically we use all the approaches to ensure that the person that doesn't have internet, they can use their phone. If you're on WhatsApp, if you're on X, we can get you on those channels to be able to assist you get your mental health status checked. So those are the things that we're using. So for the past 5 years, what have we been able to do in the countries that we currently operate in? We've been able to have at least 7 million people access the system and check their mental health status, going into screening, like we are saying, prevention. So we keep on ensuring that you get screened over and over again. So we are just using the systems that are already in place. Like we are saying, and I want to echo what Judith said when she says that SHA is actually working, because all these healthcare facilities, they are using SHA. And the SHA has already said that they have a mental health budget in there. So that's why we're saying it's going to be affordable for everyone. So everyone must be on SHA so that you're able to access the services in each and every healthcare facility that you visit. So we are again saying we are working to integrate this with SHA. We are already in conversations with them to see how this can work. So if you're in this room and you're not on SHA, we are saying kindly ensure you're on SHA. Yes. So we have currently we're working on a model to ensure that this works. So we are doing the public-private partnership with the government to ensure that these services are entrenched into the healthcare system, so that everybody is able to get to know their mental health status. Because we believe if you get screened over and over again, then that way you're able to get treated on time. It's going to be cost effective for you, and all of us are going to enjoy a country where we're able to manage our mental health states. Thank you very much. For more information, kindly let us have this conversation. We believe when we're able to take care of our mental health state, we are going to achieve the goal for 2030, where we are focusing on a healthier country and a healthier Africa at large. Thank you very much.
I will call on stage our panelists today. They're incredibly gifted individuals, as I mentioned.
Hi, my name is Tom again. I'm from Europe, Africa. Like I mentioned, background in machine learning and data science. So we're building smart systems for radiology, radiology specifically.
Good afternoon. My name is Dr. Irene Choki. I'm the County Chief Officer of Medical Services, Nairobi County. I dropped that one to feed you. And I'm a pharmacist by profession.
All right.
Hi, my name is Naida Mugese. I work with the Graph Guide, seeing some startups present. Actually, most all of them we've supported them through one or the other program that we have as an organization. And I am the incubation and finance lead. My background is in business and finance, and I've been working with Google for about 6 years now. And glad to be here.
All right, welcome to today's session. I'm very grateful that all of you took the time to come and talk to the audience today. Unfortunately, the audience is on this side and they're sitting here, so maybe we will place them. And I will start with the first question, and these are going to direct to Tom because you have a background in technology. How can technology fundamentally transform healthcare access and outcomes in Kenya, especially for underserved populations? I think I've listened to you before and you have said Kenya and Africa are under-serviced and under-resourced in healthcare. So how can technology be the bridge to this? I think we have to move around. Thank you.
Thanks, okay. I've seen technology as where the financial tech was almost 10 years ago, and probably even 20 years ago. Because 20 years ago, if I told my grandfather that he didn't need to come to Murang'a at the end of the month to bring money, that he would send money home using his phone number, he would have probably thought I'm out of my mind. He would have rather trusted a village mate going to Murang'a to take money. So, but today, if you're going to Murang'a and I happen to come from there, no matter how well we trust each other, I will still not find the need to give you the money to take home because I can do it on my phone faster, better. And that's the potential of technology in healthcare. Right now we might have a lot of challenges, or how do I feel if my medical image is analyzed using a large language model? How do I feel if the diagnosis that I'm getting is of maybe CIDP or something like that? So it has to be a process. It's a process of trying it out, improving it, because every new technology has a few challenges, different challenges when it comes to how we develop it. But with time, I foresee technology would shift healthcare just as how it has shifted the financial space today.
I think it's very good that you have given that analogy because I think sometimes when we are in the heart of change, it's very hard to maybe visualize where we're headed, especially in the field of AI. We feel like most people don't understand what is underneath, and at the same time, in terms of adoption, it becomes a challenge because we do not see. But at times, I think what we need to have is a more broader and solid vision in terms of what we want to achieve, and maybe now technology becomes this enabler. And I will push this question to you, Snyder, because you have had the experience of working with startups within the healthcare space, and maybe you can do for us what I typically call a map. What are we seeing in terms of the innovations coming through Vilco? What are you observing?
So for a long, long time, we've been seeing telemedicine innovations, and there are so many of them. And it's honestly quite a blessing to see a lot of entrepreneurs that are in the room coming up with innovations that no one has thought about, like clinics, like Ambulex. And this is just, it shows the out of the box thinking. There's AI, which we've also been quite like a pioneer in supporting such startups, because like you said, when people see new things, they tend to wait and see. We will not invest in such because they want to see traction in order for them to adopt. And so I would say it's AI, it's telemedicine, it's emergency solutions, it's insurance, microinsurance, and all kinds of innovations that you can think about. And this morning I was actually just thinking that from a national perspective, we see people talk about, patients in the rural areas cannot access specialized doctors. But guess what? There's innovations actually trying to solve that. And the problem with that is that in as much as there's innovations that are trying to solve these problems, the uptake is not yet, it's not there. So I think that's where we hit the wall as an entrepreneur support organization, and even speaking for innovators in the room. So there's solutions, but the uptake is not there.
That is quite interesting, and I think I'd like you to respond to that element, Erin. How do you think that we can be able to push this uptake? Because I think it's also a challenge that we have experienced from Neurolabs Africa, where you have to explain to the hospitals, you have this problem, we can solve it, but it's still a challenge because I think maybe the conceptualization is challenging for them, or maybe the compliance, the regulatory environment, and all that. So how can we push this uptake? Because there's this solution. What do we do?
Thank you for that. Yes, that is a challenge in our facilities. And one of the issues is resistance to change. Okay? So we have a population of healthcare workers who resist change. So ours is to find ways of capacity building, where we are building on their, we're educating them, we're making them efficient, digitally and compliant digitally. So, and we introduce slowly by slowly. Even with the technology, like Tom's grandfather definitely needs a lot. He probably needs a lot of training and acceptance. So ours is to educate and even demystify the technologies and show how they create efficiency, even in terms of their workload. Creating, just removing a lot. Paper is very tiring. So as we look at adapting technology, it helps us to just create efficiency. Reducing all that paperwork at the click of a button. These modes again, we're talking a lot about AI. AI is actually assistive, like you say. It's generic intelligence. So it's there, and it actually allows people to work seamlessly. Like in the healthcare space, health workers can actually deliver services seamlessly using AI to get assisted in terms of patient information and stuff like that. So for me, maybe in our facilities, we look at capacity building. That's the mainstay.
Right, capacity building. I have another question for you, Tom. This is with regards to the vision here. And I think also you've had a couple of people mention SHA. We have SHA, marketers and promoters in the room. But I want us to think about the vision of how a tech-enabled healthcare system for Kenya would look like. Away from SHA and Money Matters, how generally can these look like for us? And how can we all be able, in terms of democratization, how can I access? How can you grant for the access? How can everyone, even in the northern of Kenya, the remote places of Kenya, how will it look like for us? Or how should it look like?
Should look like universal health coverage. In that.
You might have to explain that.
Okay. So I'm thinking of this today. If I wanted a simple loan on my phone, and I request, for instance, let's say KCB and PESA, they'll get all information from all financial lenders in the country. It's so bad such that if I visit a neighboring country like Rwanda, and I want a loan there, they'll be able to achieve the same, but we can't achieve that when it comes to healthcare. That's why when you go to Egypt, we probably be misdiagnosed of a pneumonia or tuberculosis because they have never seen such a case. But if they had their data, probably they would have much more informed decisions on how to handle your specific case. So I look at I look at it as being able to share data seamlessly, being able to access, you see the little things, you see, you overpaid your visa maybe by you exceeded by the 48th day, all these little information, including like how you felt 2 weeks ago. It might be what we normally write on the cards. We all need these to be captured digitally. So that when we want to get to an age of precision medicine, we can be able to get to that reality. And that's the reality of AI. How do we do this, honestly? Because we're dealing with rural, urban, and some places have very limited internet accessibility. So what I think, or what we have tried to do ourselves, is try build technologies that use very minimum connection requirement, and even keep data and probably connect it to the universal health coverage once in a week when there is connection, or once in a while when there is connection. And now our system can just work on a mobile hotspot, so you don't need lots of data to be able to achieve this. So, and I believe the internet is coming in, even with government working with organizations like Starlink, securing some of these devices for our marginalized hospitals, schools, and so on. So we're getting there, but we need now just to have the infrastructure in place, like how do we achieve low-cost models when it comes to data uploading, data sharing, and all that.
Right. I think you have brought a very important point into the discussion, especially the infrastructure bit and also the data. Typically and traditionally in artificial intelligence, people talk about the three aspects of data, infrastructure, and people. And I think this is not just within just technology, but every sphere of life, we have these three elements. And one of the things that you also mentioned, Tom, is that our hospitals are deleting data, some of them after 2 weeks. So we're thinking about how we can leverage DG Health, and here we are with hospitals deleting data because they don't have the infrastructure, they don't have the know-how. And I want to push this question to you, Slorina. How can we build this capacity in terms of infrastructure, in terms of data? Because you are a finance person, and also that is another area that we need in this entire equation. How do we respond to some of these things, and how do we build them? Because we need that foundation.
No, that's a really, really good question. I think the future of healthcare and innovations, even if it's not in healthcare, is in data, right? And from a perspective of someone who has supported healthcare startups, some founders actually have no clue the worth of their data or the data that they collect just from integrating even with private facilities, right? And so what we are doing as We'll Grow is essentially making sure that the solutions that come through our pipeline are, first of all, enlightened on having the proper standards and making sure that whatever they're building is really interoperable with the national healthcare systems, right? And by beginning there is then encouraging them to design solutions that if the government were to uptake, the government will actually look at it and say, hey, I think you have created an impeccable solution that is able to integrate with our national health systems, and so we can actually have you in mind as we are creating or as we are thinking about budgeting for innovative solutions. And what comes to mind is really just building with the needs of the customer in mind, which in this case, especially for healthcare, sometimes it's the government that is actually going to pay, right? And so you have to think beyond accessibility for the patient, and also add another layer to it where you're saying if the government is actually the one going to pay for healthcare, especially in rural settings, how do we design solutions that actually speak to the needs of the government? And then also looking at creating awareness, like she said, where we are designing products and tagging along the healthcare workers, community healthcare workers, as we design the products, not just designing it in isolation and then putting it on them and hoping that they're going to take it, right? So as you're designing as an entrepreneur, and this is from a perspective of someone who has really spoken to many entrepreneurs, is designing with the needs of the users and the payers in mind. I think that will be a very important thing. And then when it comes to infrastructure, one of the things that is really a pain is cost, right? Facilities need computers, they need internet, and to be honest with you, there's a lot of financing that is flowing into the continent. And if you think about it innovatively, in that when you're getting funding, you're not just going to deploy it blindly. You're deploying it collaboratively, such that when innovators are coming up with the solutions, we have a facility, you fund the innovators to implement in those facilities, and in turn, supporting the innovators and then supporting the facility as well. So I think there's a lot of opportunity in terms of looking at financing, which we obviously need to lay the ground, the foundation, and using very innovative financial models to make sure that the innovators win in terms of making their cut or money, the facilities win, and it's highly sustainable. Yeah? And I think these are some of the things we can achieve that if we sit down together and come up with unique financing model that are not just grant dependent, but also thinking about sustainability in the long run. Yeah, sorry, I said too much.
That is okay. Actually, this provides the perfect segue because I think you have mentioned the building in isolation, where we do not immerse ourselves into our customers' needs, our African needs, our local needs before we ship to the market. And also, you had mentioned the Arctic issue. But I want us now to respond. I think I really can respond and also Snyder. What are the challenges that we have in terms of shipping these solutions? Because clearly people are building them, right? And clearly there is financing that is coming in, though some people would argue it's not getting to them. But what are the challenges we're having in terms of now, other than the two you mentioned, in terms of shipping these things? I agree you're working on an incredible project, but generally now, what are these challenges that you face, maybe from your own perspective? And Snyder, you can also respond from what you observe. Get started here.
Okay, thank you for that. Some of the challenges, one of them is, in our situation, she mentioned interoperability. So you find we have so many of these technologies that are not interoperable, so it creates a problem. So we have to find a way of making them interoperable so that they are all speaking to each other. So even in terms of apps, applications, mobile applications, systems, digital systems. So we find everybody is coming up with one and they don't speak to each other. It's like a tower of Babel. So
I know.
it's something we need to, work around so that we have seamless interaction. Again, there are very remote areas in this part of the country. Much as we say Kenya is advanced, technologically, we still have very remote areas. So you have to go and stand to do a certain Safaricom trip or Airtel trip just to, access, even making calls or something like that, just accessing technology. So we probably still have a long way to go in terms of that. Again, uptake, like I said, of new technology. And I totally understand technology is just like medicine, it's dynamic, highly dynamic. So one day you hear with this equipment, tomorrow it's obsolete. So you have a new one, so you have to go through training again, and that kind of thing. So you find even as you get new technologies, people are resisting. And these are real fear, especially with a certain cohort of, the Gen Zs will adapt technology very fast. I think most of the people here are Gen Zs. But Gen X is another different story. So that becomes an issue. And you find they have the experience, so you want to keep them. to be able to offer the kind of services because of the experience they have, but we'll be looking at also making them efficient. So to merge those two, that becomes a bit of a challenge. So also financing technology. Technology does not come cheap. It's heavy on the finance part, yeah. And I think Daktari there with the equipment, I'm sure they don't come at a small. The more advanced the technology, the higher the cost. And I like the model, to be very honest, so that it's shared. Yeah? And perhaps I'll still engage in on knowing how they train people to use that. But yeah, those are some of the challenges we're facing, technology. Yeah? Thank you so much.
I think you've covered it quite well, and maybe especially around AI, education is super important. And it's because tech and AI is just an enabler. At the end of the day, there's need to actually tell healthcare workers that this is not going to replace you, it's actually complementary. And again, it starts like way early in the design phase by like having conversations and talking and engaging all kinds of stakeholders. So yeah, I completely agree with you.
All right. Tom, I think you've had a lot of mentions about interoperability, and I think you have some understanding of that. So maybe you can respond on how we can make these things more communicate better, or maybe from experience what you've seen. And in the same breath, I want you to respond on how artificial intelligence now, from your experience and expertise, can improve detection. We've had about mental health, we've had about the cases that you mentioned of pneumonia and the rest. We've talked about local disease balance, so respond to that. How can we use artificial intelligence to do these things? And also, how can we become more interoperable?
I think towards building systems that can communicate with each other. And it's all about intentionally building towards that reality as entrepreneurs. And this is very much realistic because you're not coming into a perfect market. You're coming into a market that, for instance, if it's us, we need to integrate to our HMIS in our hospital to be able to have seamless connectivity. So I think it's intentionally building with that in mind. And I think when we do this, there's a lot of potential because all these are data points. You see, Judith placing an ambulance on Gov Road was not just guesswork. It was a lot of data points that needed to be looked at to understand that. And when you place this ambulance here, the response time within a certain geographic area will be 10 minutes, will be 5 minutes, and so on. Again, imagine you have to spend an hour with a therapist. So imagine you would have a technology that already scores you. So comes to see when you go through therapy, there's what we call the emotional moments. So you're starting off, you're crying, and someone is trying to encourage you. Imagine you communicated with an LLM that was able to take you through this phase. They have a few findings, they have a few. So that means you end up spending probably 20 minutes less, and the therapies of this schedule probably you might have required one more session, and you might have required to pay for that session. So that's the potential of technology in most of these technologies. It's coming in to help. So that means as a therapist, instead of seeing one patient within 2 hours, I can be able to see two, which also means more income for me, so better life for me. So technology is all about helping, depends on how you see it, because today, for instance, if there's somebody who really hated them as our banks, because they got these guys are here to replace us, and that's what happens with a lot of technologies. If I tell therapists, somebody will be consulting online, they will be consulting on a large language model. he or she is inclined to think then what will happen to me, that will make me absolute in the wrong line. But look at the size of reduction in banking halls. Today banking halls are size of a city. So that means banks are able to save on costs when it comes to on how much they used to spend.
The need for proper clinical validation and clinical trials. You can imagine if Tom decides to wake up today without the validation, goes connects into a hospital and decides, I am going to treat everyone today. So why do we need clinical trials and that validation?
Thank you very much. Kiri, let me just mention, I really did bring out a point after I said something. In medicine, you cannot eliminate the human touch. Medicine is very social. It has a very big social aspect. Yeah. The fact that I'm able to talk to a doctor or a clinician, it makes a lot of difference. So we cannot totally depend on technology when it comes to even like diagnosis. But yes, to some point, yes. But then it's a balance. It has to be balanced. It has to be balanced. When you talk about clinical trials, my favorite. And we need to clarify about clinical trials. So all these medicines that we take, they go through some processes, stages before they are put in the market. So that you go and buy your, for instance, and I'm not marketing anybody, Panadol. So we have a stage 4, and that's what we call clinical trial, where we subject this molecule, and most of the time it's new molecules, to the human population. So we recruit humans who will participate in taking this molecule, and then we record the outcomes. So if you look at your medicines, you'll find a leaflet with a lot of many information. I don't know whether you've seen that. So that is information that is generated from the clinical trials. So technology and clinical trials, very interesting space. So like I said, 50-50. Yes, we're using technology to collect the data. Very, to create efficiency when we're collecting that data. But nevertheless, you still have to issue this medicine to this human being and collect data from them. They can have an app that is connected probably to this main technology that we have in the center, the clinical trial center, and probably they can actually be reported. Or they come physically and you're able to key in, and you're able to look at the data. And even using AI, we can actually compare and help us to even analyze the data. So we're not totally, in fact, technology has really advanced health. So even in clinical trial space, we're not using out technology. It's a balance between both human, still the physical, and the technology. When it comes to genomics, bio everything, so you're looking at innovation of new molecules, and for instance, let me talk about nanotechnologies in medicine. So the nanotechnologies have brought efficient ways of delivering medicines with a lot of precision, like in cancer, for instance. So you find new molecules are designed in certain ways in very tiny microscopic particles and to be delivered precisely to the area of time, so that it's not affecting. So we're minimizing the overall we call them adverse reactions of drugs, even in vaccines. The same vaccines using the same technology to deliver the vaccines to the population. So there's a lot of benefits that come with all these technologies.
So I will ask you, I think, the final question before we ask the audience to respond to what we have been talking to. But what do we see in terms of, and this is to all of us, in terms of digital, all of these technologies we're talking about, emerging technologies, there was a mention of blockchain, there's a mention of AI, there's IoT, all of these different things. What do we envision? Or generally, when we think about it in the next 10, 20 years, what should we be anticipating, expecting, based on your backgrounds and experiences, maybe so that the audience can understand what your visions are for the space? So So we can start with your slide and everyone can respond if they have a response.
I see data being like at the forefront of informing, the direction of investments. I see big pharma like really interested in companies that have realized that data is really, really key, and that's really just if you look around and see how many healthcare startups have been acquired and by who, you will notice that the ones that are being acquired are the ones that really realize that data is really like gold. Then you see a lot of regulation. There's Digital Health Act that came about sometime last year, and in as much as people are really looking to innovating, it's good to innovate and come up with products that have some ethical background and some solid backing in terms of the technology, because it will get to a point where the government will say, hey, we want to look at your tech stack or whatever, however you guys call it. So just having that in mind in order to not take shortcuts now that will end up hurting you, the business, and the people around you. And I think that's something to really look out for in the next 20 years. Regulation and the importance of data. And also, and I will speak on behalf of an entrepreneurial support organization, is also innovating with an end in mind. And by end in mind is really looking at the disease focus, right? Right now, like maybe 30% of the population have NCDs, and NCDs are here to stay. The trend is definitely just going to go up and up. So how about we stop looking at customer convenience? Not really stop, but complement that with disease focus, right? So you're looking at, hey, hypertension is probably going to be there for a long time. Diabetes is going to be here with us for a long time. What other disease areas are going to be a problem, and how do we innovate around those disease areas in as much as we're looking at convenience for the customer? Because tech, again, is just an enabler, right?
Yes.
Yeah.
Just to add to what she's saying, also, for me, I see better care in future. Better ways of managing our clients. Again, in terms of surgery, we are advancing very fast. Minimally invasive procedures where we don't have to cut up somebody right across. So you just need to make small incisions, and you're able to do some small probes, and you're able to perform just minimally invasive surgeries. Also, remote monitoring of clients who are very far away. And I'm glad Tommy has spoken about telemedicine. We are already on it in our county, Moranga. We are doing telemedicine. We're doing telemedicine already. So the patient is saved the cost of going to the facility. So in terms of monitoring, even for the non-communicable disease, the diabetes, the hypertension, the patient can just probably go to the nearest facility and they're able to access a specialist using telemedicine. And then again, a very important technological advancement, I'm seeing disease surveillance, improved disease surveillance. And here I'm talking about, for instance, the case of Mpox. You can see Mpox, Ebola, all these highly infectious communicable diseases that travel across borders. So when it comes to disease surveillance, technology is the in thing. And so far it's working very well, because I know the East African countries, they're able to communicate very fast when an outbreak is picked. And even at the point, using GIS technology, an outbreak can be picked, a hotspot for an outbreak or a disease can be picked very fast, and it's communicated across, not just East Africa, across the world. Yeah, so that now we become more responsive, become more responsive to that. And that's why most of the time we find some of these illnesses are contained very fast. Because diseases like the mpox, the Marburg, the hemorrhagic, we call them hemorrhagic fevers, they are very aggressive and they can wipe out populations very fast. But because of technology, we're able to contain them. Have vaccines. Look at COVID. What saved us? It's the vaccines. Yeah? And now the mpox, we have a vaccine as well, which take 2 doses 4 weeks apart. So technology is going to take us to the next level in terms of healthcare. And yeah, it's welcome. But we're still not rolling out the human touch.
No, we haven't. Tom?
I see healthcare, I see the future as very personal in terms of being able to speak to me individually, care for my needs individually, especially when it comes to healthcare. And I like to borrow a lot from what rather has happened from the fintech space. You see, and it's very dynamic because we need to work together and not see innovation as an innovator alone. I need to know how to work with government, because if there's good innovation, then we have a better government and we have a better way of even articulating most things. For instance, by the time I was 5-7 years ago, just 5-7 years ago, you can imagine access to credit, how bad it was. You needed to have worked or even have to have shown income for at least 3 months to be able to access credit. Today, I only need a phone, and another from 7 years ago, 7 years ago, you only needed a phone and an app. They needed nothing else, just your name, your ID number, and they would give you up to, let's say, 10,000 Kenya shillings. Right? But what did the government do? We called a press conference and said we haven't licensed those people. In fact, do not pay those loans. You remember?
Yes.
Years down the line, the government failed to see financial inclusivity. Imagine there was a blasting apps, I think there were over 5 towards 10, right? Imagine me as a person downloaded all the 5 apps and got 10,000 from each app. Did I have a business by the end of that day? I would have started a business. And look at how well government would have looked, because there is financial inclusion in our country. So it's about seeing the potential, not seeing some licensing fees that we needed to have collected before and all that. So imagine the success story Hustler Fund would have today. Because imagine they had this data for over 7 years of individuals, so they would come in, give huge amounts of money when it comes to 500,000 and above. Because if you are doing 10,000 Kenya shillings 7 years ago. So in healthcare, imagine all these data points that you can be able to reach a reality where a pharmaceutical company is developing drugs for a region, knowing their genomic type, knowing their genomic data, understanding how well the impact of this drug will have on a certain population, and more importantly, to me as an individual. See? So that's what I foresee in the healthcare space.
Thank you very much, Tom. I think today we're going to have a discussion about ethics. And obviously we're not also going to have a discussion about regulation, because those are very heated topics. And I think over the last year, we've seen a ton of bills and a ton of forums to discuss the same. So we wanted to keep things very narrow today to what we can address. So if you have any questions, we can take them now.
Thank you all for that very insightful conversation. So I would have one question, specifically for Snyder. What would you recommend that startups should do to package their data in a way that it's ethical? Because the idea of selling data is frowned upon, if you get what I mean. So what would be your recommendation on how we can package our data and use that for the benefit of growing our startups? Thank you.
Yeah. I think the first thing is to show that you are locally abiding by the data office of the data commissioner.
Yes.
Yeah. So that is important, and also to continually anonymize that data and look at the people who would be interested in your data, because it's not what should I say? It's not hard to find startups that have actually been able to monetize their data. We have a couple in our portfolio that have some serious partners that really look into that, but it's definitely anonymized, and they give insights and they make sure that it's useful data. It's not just data, it's actually showing something. And so when you're talking about your value proposition, you need to also know what metrics are you tracking for someone who you're looking for to be in partnership with, for them to be interested in your data. So it shouldn't just be wishy-washy. It should be that you're actually offering them enough information for them to make a decision, and for them to benefit from that. Yeah.
I think also to add on to that, a majority of the problems we have with data do not even pertain to the access of it. The quality is a huge issue. So look at the pipelines that you have, the quality of the data that you have, and then make sure you package it really well, just to add on to that. Any other question?
Hi, my name is Robina. I know nothing about the healthcare space. I'm in the PR space, but I had this question initially. The health space you have around all the startups I've had is mind-blowing, to say the least. But I have one question. I realized just one of you, like the clinicals. You mentioned you want to scale around East Africa, right? How is your space in Kenya? For instance, I have a grandma in Kisii, right? Her caregiver is not literate. How are you sensitizing people around this type of space on what you're doing before thinking of scaling outside of Kenya? Because first we have to move on the idea of charity begins at home. Because we can take an idea that we have outside Kenya if we're not building it in-house.
So, thank you for the question. I think it's very relevant. Sometimes we maybe haven't been able to scale to the entire region of Kenya, but it's in terms of sizing up the market to be able to really, and it comes to fundraising, because most of the times you need a long-term plan, maybe 5 years. So most of the time it's, if you're able to get this fund, what is the market that you're able to address? But it is a challenge to be able to scale, and especially since healthcare has been decentralized. So different counties will have different uptake. So this is a challenge which now comes to how can government, at the end of it all, I believe for healthcare to be adapted, you have to have a fully functioning government, because majority of clients will go to the public healthcare system. So do we have a supportive government, and how do we integrate all the counties so that we're moving together at one pace?